I see Matt is here from the board. We are being live streamed. Hello and welcome to the Health, Occupations and Long-Term Care Subcommittee. We have a work session today on 3 bills. We're going to go in the order of House Bill 260, House Bill 229, and then House Bill 636. We are intending to vote on House Bill 260, which we have discussed for the last, I think this is the 3rd week, possibly the 4th week we've discussed it. I'm losing track of time. I don't expect to vote on House Bill 229 or 636, but we will begin the discussions on those pieces of legislation. So with that, I really promised Lindsay and Lisa that I would figure out who had which bills, but I can't remember who has 260. I think it's Lindsay. Lindsay. Yes, excellent. Thank you. Lindsay, can you remind us about this bill?
Sure. So this is the bill that transfers oversight of the inspection of the offices of physicians who prepare and dispense a prescription drug or device from the Office of Controlled Substances Administration to the State Board of Physicians. The committee has also already adopted an amendment on this bill, which transfers positions, funding, and records relating to inspecting the offices of physicians who hold permits from OCSA to the Board of Physicians. And after that, it's been held several times.
Okay, so the amendments have been adopted and the bill as amended still needs to be moved and seconded, right? Okay, does anybody want to move the bill?
So may I ask a question?
Well, we'll have discussion on it as soon as we have it moved. So I saw moved by Delegate Morgan, seconded by, I think that was Delegate Cullison. Okay, so now we will have discussion. Do we have questions from the members of the committee? I'm trying to pull up my participants. I don't see any hands up. So it sounds like, I understand it, I'll just say what I think, and then we can get a sentence from any of the proponents or opponents here. I think we've talked this issue to the ground. I have talked to the members of the subcommittee, and they all feel confident that their questions have all been answered, and they feel comfortable moving forward with this, but definitely do want to see those relationships clarified and work on the relationships that were discussed last week, so that we feel confident that the different agencies are working well together. So I know this is a conversations I've had with the Board of Physicians that they're definitely want to have some meetings and make sure that education is taking place on what their responsibilities are under this bill as well as with the existing law. So that's important to the committee, although I don't think it needs to be legislated. So I guess I'll call on Matt and then Dana and then Pat, just to make sure, Matt, you understand that that's important to the committee, and is there anything else you need to add?
Absolutely, and thank you for that, Delegate Kelly. And I just want to reiterate that the Board of Physicians wants this to be a successful transfer. The reason we are proposing this transfer is because we want to increase patient safety. And we certainly don't want to do anything that would jeopardize situations such as the opioid crisis in particular is something that we take very seriously. And we would not intend to do anything to jeopardize that. Regardless of the outcome of this vote, we are eager to find some ways to repair these relationships, because it seems like a lot of the opposition to the bill has been based on either issues with the actual practice of dispensing permits in general, which the bill doesn't really address at all, or with that relationship with the Board of Physicians. And while I can't really speak to the practice of dispensing permits, because that's kind of well beyond the scope of this bill and well beyond the scope, it's something that's been settled law for quite some time. As far as the relationship, we are happy and eager to find a way to, repair that relationship, again, regardless of this bill.
Thank you. Dana, did you have something to add?
No, I don't have anything to add. MedChi supports this bill. We think it'll actually improve oversight and regulation. Thank you.
Okay, Pat, I know you had something you wanted to add.
Yes. We would ask that this bill be referred to Judiciary Committee if it is going to proceed. And that is because if the bill becomes law, there will need to be review by the Judiciary Committee, which oversees the Office of Controlled Substances Administration and the functions it performs pursuant to the criminal law Title Title V, and Subtitle VIII. And the Office of the Attorney General is deeply concerned that the Office of Controlled Substances Administration will not be fully funded or fully staffed without action by the Judiciary Committee on this bill to ensure that that does not happen.
So you think there's specific action needed by the Judiciary Committee to ensure that there's funding, appropriate funding for OCSA?
Full funding and full staffing.
Okay.
And yes.
So I think the issue then is that we just need to make sure that OCSA isn't inadvertently underfunded for the work that they need to do, but accidentally have as a consequence of this bill. That's what I'm hearing you say. And we need to run that by judiciary and make sure they take action to ensure that they have the appropriate funding and staffing.
Well, yes, at a minimum. And,
yeah.
and there are other consequences of the bill that fall within the purview of the Judiciary Committee.
Okay, that's great. And we have a process, Pat, just so you know, of communicating with the other committees. We don't want to bring a bill out to the floor that is in the interest of another committee's jurisdiction without having run it by them. So we will certainly take your advice on that. And I appreciate that. That's very specific, tangible thing that we can do to make sure that everything is working appropriately as we intend. So thank you for that. So the bill has been moved and seconded, and I think we've had discussion. I don't see any more hands up from members of the committee. So let's call a vote. All in favor, say aye. 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 Anybody opposed? I don't see any hands up. So the bill passes the subcommittee unanimously, and we will consult with the Judiciary Committee as has been recommended by Ms. O'Connor. Thank you for that advice. Let's move on to a discussion of House Bill 229, which is Delegate Young's bill, Pharmacist Administration of Maintenance Injectable Medications, Treatment of Sexually Transmitted Infections, which I think is a Lisa bill.
Yep.
Yes. Okay.
House Bill 229 alters the definition of maintenance injectable medication to include a medication that is administered by injection other than intravenously and treats a sexually transmitted infection and is not a vaccine.
Okay, I know Delegate Lewis Young is here. Do you have something you would like to say on this bill before we go to stakeholders?
Yes, this STI component was added on to the bill last year, passed in the Senate. The House passed the bill without the STI. I think there was a feeling that because the STI came on late, we should treat it separately this year. So we're back. It has moved through the Senate and crossed over. We have a major STI problem in the state of Maryland. We're the 7th highest in the country. In fact, there was an emergency order last summer from the governor to add STI injectables onto the capability of pharmacists to provide this injection. In our hearing, there was overwhelming support. There was only one objection from the insurance provider agency. It was a bit of a stretch trying to claim that this isn't a maintenance drug and that it would add to our mandated benefits. It won't add to our mandated benefits. It's already mandated. It just increases the access points. Also, we have seen a letter from the Maryland Department of Health, the Board of Pharmacy, that says that the language of the bill does not prohibit a pharmacist licensed by the board from administering maintenance injectables for the treatment of STIs. So I'm hoping that you all will move this. It will go a long way in treating STIs, which is a major challenge for us, and access is critical. Thank you for the opportunity to speak again.
Absolutely. Delegate Morgan, I think we have some stakeholders here on this bill. Do you want to ask the sponsor a question or wait until we hear from any of them? Whatever you prefer.
I'll wait until then.
Okay, so I see Aaliyah Horton is here. Delegate Young, do we have anyone else here on this bill? Do we have a carrier represented on the, I don't see anybody else here. So let's see if Aaliyah has anything to add, and then I'll search and make sure we don't have anyone else on the bill. Go ahead, Aaliyah.
Hi, I actually don't have that much more to add. Did I freeze? I'm sorry, I'm having a little bit of trouble there.
You did, but you're back now.
I'll talk fast. I don't have that much more to add. I did mention in the hearing about kind of restructuring that section to address the definition, but it opened up a whole can of worms that I don't think we're really prepared to do at this time. And the bill passed without amendment through the Senate. And so I think we are in good shape, and I'm happy to answer any questions.
Okay, I'm cruising through my squares just to make sure we don't have anyone from the carrier community here. Speak now if you're here. Okay, let's hear from Delegate Morgan.
Okay, I got a couple questions. First, so if we expand this to pharmacies, how many more pharmacists would be qualified? Like how many does this bring? Like you were talking about access points to this. How many does this add?
To that, the vast majority of pharmacists are already certified under the immunization certification. And so they would just need to get some additional education on the specific STIs and the medication. And that's something that our organization is prepared to provide for the community. So in terms of the actual physical training that needs to be done, the vast majority of them have done that already.
So when we're talking about STI medications, I guess the concern was, having more drugs like renewable drugs, I guess for like HIV, you have to take a monthly or something like that. For STI, isn't that mostly treated just with an antibiotic over like a short term?
Well, this is something that was actually brought to, and I'm sorry, my internet connection is bad, but I think I got
I see you freezing up there.
Yeah. From what my understanding is that this issue was actually brought to our community as a concern because the first line of treatment for these infections now has moved to injectables because they're more efficacious than the oral medications. And so this is something coming from the medical community to address.
I guess my question is it just a one-time injection, like a shot of penicillin? Like it's not like multiple injections.
That I can't speak to. I believe they are more than once. There are some that are, I think it's 3 over a course of time. I can't speak to that. I could get back to you on it.
Okay.
But they are prepared. I mean, the maintenance injectable medications, the whole statute is under the expectation that there are a course of injections that have to be made, and that may vary by the medication.
Okay, thank you. Thank you, ma'am.
Thank you. Delegate Krebs.
Yeah, along the same line of thinking, I'm not opposed at all to pharmacists doing this. The concern, and I had down here that we needed amendment for clarity on what exactly is maintenance medication. I don't know if that, you said there's no amendments, but that was what was in my notes. And this whole issue of whether something is maintenance, a course of treatment versus maintenance. And I don't know exactly the difference, but it seems like this is a course of treatment because you just said 3 doses. That's more than maintenance that you do forever. So do we have any idea, what it would look like to define what maintenance medication is? That's the only concern that I have. That was what came out of our last hearing. I didn't know if anybody picked. We move on and get, when somebody has concern, we get an amendment drafted. I don't know how to define.
Delegate Krebs, I can tell you that Matt Celentano is actually trying to get into the meeting right now, so he should be here and able to answer.
For him.
Yeah, so hopefully he'll be on in a second. I don't know if Delegate Lewis Young wanted to try to address that until we.
And maybe he could offer some language again, maintenance versus a course of medication.
Okay, he should
Hi,
be.
sorry, I was having a hard time unmuting. I think we're seeing an objection in the House because it passed so swiftly in the Senate, which is unfortunate, but it happens. I'm not a medical professional, but STIs cover a range of sexually transmitted diseases. And so the treatment might be slightly different for each one and the severity. In any case, a pharmacist is not permitted to provide these injectables without the instructions of a physician. So the pharmacy would be maintaining the prescription of a physician. So it's very difficult to give one answer, given, is it syphilis, is it gonorrhea, or the other kind of STIs that are covered. As someone mentioned earlier, by trying to go down that rabbit hole of defining maintenance, it will overly complicate the bill and perhaps provide unintended consequences, or maybe intended consequences. I believe there may have been an AG opinion on this issue, and I will try to dig for that and find that out. So
Let me mention there is already a
allow
current
this whole issue to be a showstopper.
I think the question becomes, there is a definition in law already on what maintenance is, and they don't believe this fits into it. That's why they want to consider adjusting it, because there already is a definition. This doesn't fit that definition necessarily. It's gray. That's the question.
Okay, I think that Mr. Celentano is here. Is that right? Are you here now?
I am.
Excellent. So instead of let's presume we know what your concerns are, let's hear your concerns, and then we will hear questions from Delegate Saab and Delegate Morgan. Go ahead, Matt.
Thank you, Delegate Kelly, for the rapid response there the last couple of minutes. I'm happy to be able to join. In general, insurers are not opposed to the concept of getting beneficiaries the drugs that they need to treat infection. Our concern was that when we negotiated this bill with MedChi a couple of years ago to increase the scopeability of pharmacists to do injectables, that there were a couple of things that were agreed upon with all the stakeholders. One being that it was a maintenance injectable drug, and two, that the physician had to give the first dose of that drug to make sure that there weren't any ill consequences or side effects. As someone who has seen the side effects go badly in just the COVID vaccine in the last year in that 15-minute window when they told you, we felt this was pretty important for patient safety. Our biggest problem with this bill is that sexually transmitted medication by nature does not fit into the definition of a maintenance injectable drug. It is an entirely different treatment. The drugs are very expensive, and we think that it's properly done at the physician level. That was our sort of position. It just falls outside of the scope of the compromise that was reached over the course of a couple of years.
Okay, so now that this bill has passed the Senate, are we working on trying to come up with an amendment, or are we trying to make the bill not pass because we don't think there's anything we can do to make it fit, to make it workable? How can you help us accomplish the goal of this bill in a way that's comfortable for you?
Well, first and foremost, I don't think that we should try to insert sexually emitted infection drugs into the definition of maintenance injectables.
Okay.
So that would be sort of suggestion number one. Number two, I'd like to loop back just real quickly to some of the members to see if they have approaches in other states where there would be some level of oversight on these particular medications.
So maybe there's a different approach. Let's hear from Delegate Saab, then Morgan, then back to Delegate Lewis-Young. Delegate Saab.
Thank you, Madam Chairman. Actually, Matt answered a couple of my questions, so I'm going to hold off.
You're okay. Okay. Delegate Morgan.
Yeah. My question's for Matt. Again, I think, well, at least myself, I'm for this. I think we want to expand this access, but why would STI medication be in? Are you saying it's currently in the maintenance and effort?
No. Sexually transmitted infection drugs would not be considered maintenance injectables. Maintenance injectables, when you're thinking of, I think would be fall in the lines of like diabetes medication or something that's ongoing. A lot of these drugs are one or twice, one time, 2 times.
Right. Okay. And you're saying why would that be a problem?
Well, it's a different.
I thought you were saying it was a maintenance issue.
It's not a maintenance injectable drug. And maintenance requires ongoing usage over time. And usually you find that's why you have the doctor inject it the first time, to make sure that you're not going to have an adverse reaction to it. And then the pharmacist can treat you over time. Some of these drugs are once or twice and that's it. So it just doesn't fall into the
I understand your concern now. Yeah. Okay. Thanks for clarifying that. Thank you, Madam Chair.
Okay, let's hear from Delegate Lewis Young, and then we'll go to Aaliyah Horton. Delegate Lewis Young.
Hi. We did have a similar conversation last year when the larger bill passed. In not all cases does the physician want to do the first injectable. In many cases, the physician doesn't necessarily carry the product to the extent that a pharmacist does. So there are times the physician actually wants the first injection to come from the pharmacist, and the physician will authorize that. I think I'm going to repeat again, it's a real stretch to try to hinge the objection to this injectable being more accessible on defining it as not maintenance. And that is the only loophole. It's a real stretch. It passed without argument, 47-0 in the Senate. And so the strategy is to kill it in the House based on a real stretch of an argument.
With all due respect, with all due respect.
No, go ahead, Matt. Go ahead, Matt.
I say, with all due respect, Del Young, we've been completely consistent on this. We said the same thing in the Senate that we have said in the House in both years, and I don't have a strategy here. We've been saying the same thing for the last 2 years in both chambers.
You didn't testify.
Wait, no, Karen. Delegate, it's okay. We're at where we're at now. We know the bill is out of the Senate. I'm hearing that this is an approach that maybe the carriers have concerns with. Aaliyah, your hand was up and then down. Did you have something you wanted to add, or are you okay right now?
Yes, I would just say that, yes, what Matt was saying in terms of the work that was done for the administration of the injectables medication that passed last year. There were a whole host of people that worked on that. Our broader goal was broad range medication administration, so we wouldn't have to come back every single time there was some new public health issue. In 2020, it was brought to the attention of the pharmacy community that there was a really strong need for pharmacists to provide these injectable medications to treat STIs because of the epidemic going on in several parts of the state. To the point where we sought to get some type of emergency order. We had physicians from all across the different spectrums, public health, STIs, primary care physicians, you name it, really begging for pharmacists' help to get this treatment to their patients. We don't get involved in what the what the physician prescribes. What they're saying is that they need the pharmacy community available to be able to administer these medications. So I want to take this particular issue out. Senator Lamb brought this up last year because of the issue that was raised in 2020. And he tried to kind of stick it into the bill. And I will say that I did stand on the side of saying, let's set this aside because we didn't talk about it. But the issue is still there and it needs to be addressed. And this was determined the best place to put it. I did offer to see if we could try to fit it in a new place within the statute. But when I started that conversation, it opened it up to not only change the section, what is it, 509, 12-509, folks wanted to open up 12-508. And I don't think we want to get into changing immunizations because all of those fit under pharmacists administering medication. So that's vaccinations, that's the long-acting injectables, it's the STIs.
Lord knows we don't need another vaccination bill on the floor this year.
Right.
So-
And we don't want to get into that, but that opens that up. It really does, because there are things that need to be fixed. And if we're going to start moving these things around, then we need to address all of them. Like Delegate Young said, it's fully passed the Senate with no amendments. If we need to make some modifications, let's maybe do that next year. But I think we have a real public health crisis that the physician community has asked for help, and we are trying to address that and provide access.
Okay, so I'm looking in the bill file right now to see if we have anything from the physician community, since they have seem to have a role in this, but I don't see anything. I see.
If you look
and supporting
in the testimony that I provided, there's on the last 2 pages, there are about 20 different healthcare providers, physicians from different practice settings around the state that have signed on to this effort. And they're the ones that are specifically working in this issue.
So they work specifically in this space and they see this as a potential solution for what they consider to be, a dire need. Okay.
Yes.
And it looks like MedChi, I'm asking this question, I guess, to Matt, because it sounds like the carrier's position is that we would like for physicians to be dispensing the first dose in anything that's a maintenance injectable. And that's part of the compromise we reached just as in this committee recently. We're not hearing from MedChi that they think that that's an important standard. So can you give me a little bit more information, Matt, on sort of what kind of approach you think might work to accomplish our goal? Or can we talk about next steps for maybe, if we come back, to this, it will not be next week, because next week we're doing workforce issues. So it would be the week after next, but that would give us some time to sort of think of ways to address the carrier's concerns while meeting the sort of concerns that have been addressed by the provider community and the pharmacists. Matt, thoughts?
I would be happy to try to come up with continued, work on this. If it's just moving the STI medication out of the definition of maintenance injectables, that would be a great first step. But two, to Delegate Young's point and leadership on this, I appreciate it. I understand what she's trying to do, and I think the intent is great. And we should be doing everything we can to make sure that folks that have been exposed get the proper medications that carriers are already covering. We just want to make sure that it's done in a fashion that is not sort of putting a square peg in a round hole of insurance operations.
Okay, so maybe we can think, I'm looking at Delegate Cullison, who is in charge of insurance over here. I don't know if we can do some creative thinking about how we might be able to help make this more doable in a way that causes less heartburn for the carrier community. But since the subcommittee is meeting on the workforce issues next week, we do have 2 weeks to try and come up with something with the sponsor and Matt. Is the committee okay with that? Delegate Cullison?
Well, I just wanted to say I was thinking along the same lines that, we can look at some potential language. And I think Matt also said, let's look and see how other states are handling it as well. And see if we can't round the corners. So.
Okay. Anybody?
I
see Delegate
one more little
Krebs.
question.
Yeah.
Before we leave, is that okay? One more question.
Yeah, of course.
I think I just don't understand. When someone gets diagnosed with STD, does that happen? The doctor goes for the test. How does that happen? And I wish the doctors had weighed in about the availability, because that makes a whole nother light on this. But what happens when they're diagnosed? Are they at the doctor, and is it because they don't carry the stuff, they can't give the first dose, or what is the situation?
It certainly depends, Delegate Krebs, on the actual diagnosis, but usually you're diagnosed or you're deemed at risk by your doctor, who then orders a test, sends you to a lab. When you're diagnosed, then the doctor takes it from there. Sometimes they have the medication shipped to them, which usually happens with an injectable, or they have it on hand and then they proceed. After you've had that first dose, they can have the physician or the pharmacist theoretically continue those dosages if that's the course of action or the course of treatment.
So can the doctor, if he chooses, if he doesn't have the medication, can he give a prescription to go to the pharmacist for the first dose if he wants to?
Not under the current law, not under the maintenance injectable law.
But so right now, if this law would pass, would at least the doctor have to give a prescription so the pharmacist knew to give the medication?
That's correct. Yep, that still is there. Yep.
Okay, just want to understand. Thank you.
Yep.
Absolutely. It looks like Aaliyah wants to weigh in on this as well. Aaliyah?
Yes, so Delegate Morgan asked, what do other states have? Other states have broad medication administration authority for pharmacists, so this is not an issue. And that's where, we consolidated it during last session to focus just on these long-acting injectables because of the stakeholder input. But really, what would make the most sense is broad medication administration authority for pharmacists. And we would not have to come back every single time there is a public health issue to be addressed. So that's how the other states have dealt with it.
What I remember from this, tell me if I'm wrong, Aaliyah, is that if we were to take that approach, we would have probably MedChi weighing in with some strong opinions.
Yes.
Okay, got it. So it's not an easy solution.
No, but I'm just saying, but that's how it was addressed. And so what we got to last year was negotiating with 15 different stakeholders to get to that point. But the concern was all that time was that we're going to have to come back because there are other areas that aren't being covered.
Right. And this is just one example that has risen to the top. Okay.
Right. And I would say that with all of these, in any case, the physician is prescribing the medication as they determine it's the best course of action for the patient. And from what we have heard from the physician community is that the oral medications are not working. And so they need the injectable. Now, depending on what they are, and this is where I can't get into the details, is if it's the pharmacist can't do it under current statute unless it's listed under the maintenance as it's provided here, or if it's considered a self-administered medication. Oops.
Right.
And so and I don't believe it's considered a self-administered medication. If it was, the physicians wouldn't have come to us for this issue.
That's helpful. Thank you. Okay, so we will discuss this again week after next. We will come back to this bill. Thank you, everyone, for a good conversation. We're going to move on to House Bill 636, which is Delegate Belcastro's bill. And I will just remind the committee it's 12:11, so we have 19 minutes. Aaliyah, is your hand up for a reason, or I think it's just accident. Okay, good. So I think House Bill 636 is also a Lisa bill, correct?
Yes.
Excellent.
House Bill 636 requires the Maryland Healthcare Commission to conduct a study regarding the quality of care provided by assisted living programs with 9 or fewer beds. The commission must work in consultation with the Office of Healthcare Quality, the Maryland Long-Term Care Ombudsman Program, Medicaid, the Governor's Workforce Development Board, and interested stakeholders.
Thank you. Delegate Belcastro, do you have anything to add?
Yes, thank you so much, Chair Kelly. And just as a refresher, this bill came out of the Oversight Committee for Quality of Care in Nursing Homes and Assisted Living Facilities. Since joining the committee, there's been a common trend with issues around quality of care in our assisted living facilities with 9 beds or less. We really lack data on these facilities. We lack information needed that would be provided by the Office of Healthcare Quality when they go around to do their annual checks. And also we're curious about reimbursement when it comes to these small assisted living facilities. So this study would create pathways for us to elevate the standard of care in our small assisted living facilities. Now, when we went to, we're really fortunate and happy that MHCC has been working closely with us. I do want to add again that we were surprised by their testimony at the hearing. Prior to the hearing, we thought we had all the stakeholders on board. They raised concerns around funding and staffing in order to complete this study. I'm very thankful to them. Right after the hearing, we jumped on a call the very next day, all of us. And I will say, Unfortunately, we aren't in a better place than we were at the hearing. We are still stuck in this rut of being concerned with too many bills coming out of HGO involving studies and also concerns around funding. And that's a difficult place to be because it can't be addressed through amendment. And it's difficult to bring other bills into the conversation. So I'm really happy Mr. Steffen is here. I hope he can shed a light on this and maybe even a path forward today for this bill.
Great, thank you. Why don't we go ahead and hear from Ben Steffen, and then we'll see if we have questions from the committee. And is there, I'm sorry, Delegate Belcastro, is there an advocate on behalf of the bill you'd like to speak who's here with us as well?
Yeah, so Dana Kaufman and Eric Colchimero and Stevan Ellis have been wonderful partners in this bill.
And I think Stevan is here. I know Dana is, I think Eric is here. So whoever wants to go first, and then we'll hear from Ben. Stevan, go ahead, Stevan Ellis.
Thank you very much. And I wanted to thank everyone for considering this bill. I'd like to say ditto for what Delegate Belcastro said, because I do sit on the Oversight Committee with her. And I oversee the advocacy program for nursing home and assisted living residents. We don't have any public information really about small assisted living facilities, and I'm very excited about that. I'm interested in looking at the analysis of data to see what's happening, if there are trends, because I'm real interested in quality of life and quality of care for these residents, and getting all of these people together to look at this, to figure out what is working in facilities, what isn't working in facilities. Also reimbursement. We have very serious issues with the cost of assisted living facilities, making it affordable for the residents and their families. And so getting more information about that. And also, I think there's a lot of misinformation in general. And I think this would help identify what needs to be shared with members of the public and also legislators and other folks as well. I think the study would really take care of a lot of issues, but even more importantly, identify what is needed for the residents of the state. I mean, we have over 25,000 people currently that could live in assisted living. That's our capacity. And many of them are in these small facilities. And I would love to have some information about public information available. I mean, nursing homes have tons of information that CMS provides. They have a minimum data set that pulls together assessment information that is available. We don't have anything like that for assisted livings, for assisted living residents. And I'd be happy to be involved in further conversation about any of these issues. But I hope that you all will consider supporting this bill. I think it's a good, and even if it does expend resources for Maryland Healthcare Commission, I do think it's a worthwhile investment. I think it'll save money in the long run, possibly decrease hospitalization rates and many other things. So thank you very much for allowing me to speak on this issue today.
Thank you. Let's hear from Dana Kaufman.
Thank you. I just wanted to point out that it's a rarity often when you get a provider association, the advocacy associations, and government officials all sitting on one panel supporting the same bill. So we do think this is a very good study that is needed. So I would ask that the committee acts favorably on this bill.
Great. Thank you. Eric Colchimero.
I'll be brief as well and just say thank you to the bill sponsor for her leadership on this issue following last year's legislation where with thanks to this subcommittee, we pushed forward a much needed update to assisted living regulations. We're pleased to have worked with Delegate Belcastro and industry to come together on what we believe is a thoughtful study of small assisted living providers who are unique in nature, who have a different approach, who often serve folks from a low income situation, who often accept the home and community-based services waiver, although we don't have as much access to that as we would like. And we're just grateful that everyone came together around this issue to look deeply at this for these over 1,200 providers who are essential to our system of healthcare in Maryland and helping older adults, including the over 40% of individuals they serve with Alzheimer's and other forms of dementia. And then one last point I would just add in Mr. Steffen's note from the Maryland Healthcare Commission, he flagged that these smaller facilities amidst our ongoing wait for assisted living to be inspected annually, he flagged that these smaller facilities are even less likely to be inspected than the larger ones. So there's really a quality of care concern here that we think this would raise, a reimbursement issue so that these providers can be looked at and analyzed and stabilized, and just a number of issues for this really important part of our healthcare system, and digging deeply about policy recommendations and a path forward.
Thank you so much. Now I know Ben Steffen is here, right? So let's hear from you. I know you expressed some concerns about being tasked with this study. Ben.
Thank you, Chair Kelly, members of the subcommittee. So I think the last paragraph of our comments are worth noting, where we emphasize we think it's an important issue to consider. There's not as much oversight of assisted living, the points that have been raised about information sources and just simply the nature of the small assisted living facilities is kind of unknown. Our concern is that there seems to be we seem to be very popular this session. There's multiple requests for studies, expansions in the scope of activities of the Healthcare Commission. So we're flagging that and suggesting to the committee to be somewhat selective. What are your highest priorities? That being said, we think when we look at the range of entities that are delivering healthcare services, the assisted living kind of is at the bottom of the rung from the standpoint of the Healthcare Commission. Our statute does not consider assisted living as a regulated healthcare facility, unlike home health, hospice, nursing homes, etc. It's not subject certainly to CON regulation, nor am I suggesting that today, but there is a bit of a gap in oversight, I think, in the state, much like other states where there's debate on whether it's truly a healthcare facility or not. So we support it, but want to be sure that you understand that our resources are not infinite.
I'm sorry, I heard some noise. Your resources, did you say, are not infinite?
Are not infinite.
I know it is the worst thing about state government, right? Do we have questions from the committee? Delegate Riley.
Thank you, Madam Chair. I'm not sure who could be best answer this, but looking over the bill and it's talking about payment as well with Medicaid. So are we saying that currently these small nursing or small assisted living locations with 9 beds and under, that they can or cannot bill Medicaid? Can somebody answer that? Do they get payment for that currently? And will this possibly change that if we do the study?
Looks like Stevan can answer that.
So the small assisted livings, as well as the large can be Medicaid waiver facilities, they have to go through the process. So many of the small assisted livings are Medicaid waiver facilities. I don't believe this is a study, so I don't think it would change how reimbursement is done currently. It would just shed light on what's being done now and what is needed. There's other funding sources for assisted livings too. There's a VA benefit, there's a subsidy, there's long-term care insurance, and then there's the Medicaid waiver, and then of course private pay. And many of our assisted livings are paid for by people's funds, what they can afford without any other benefit that they're eligible for.
So the residents just to follow up in these smaller facilities have the option to get the same waiver that those patients or residents within the larger facility.
Yes, and there's a process.
Okay.
Yeah, there's a process for that. They have to, if they're in the community, there's a registry that they can be on, and that's a long story. So if anyone needs information about that, please contact me. But also, if you're in the nursing home, you have Medicaid, you can apply for the Medicaid waiver and get it that way. There's kind of 2 pathways to get it, and it takes a lot of time to get those benefits.
Okay, thank you, Ms. Ellis. Appreciate it. Thanks.
You're welcome. Thank you.
Looks like Dana Kaufman also had her hand up. Did you have something to add, Dana?
I was just going to point out that those individuals who are under the waiver are nursing home eligible, and that there's already been studies done as a result of legislation passed by the HGO committee that shows that the reimbursement rate, the differential between the reimbursement and the cost to provide care, is extremely low for these waiver. I think there was a different, I think it was like $133 or something along those lines, but don't quote me, I'm doing it by memory. So we're hoping that this study can also shed some additional light on that issue, because we are losing Medicaid providers. They can't afford to be Medicaid providers. And oftentimes it's these smaller homes that are taking these individuals, but they often have a higher acuity as well. So it's a double-edged sword.
I don't see any more hands up from the committee. I had a question for Mr. Steffen, just to maybe get you to expand a little bit. So I think you are doing multiple other things. Can you give us a sense of sort of what other work the committee is tasking you with? I know you're involved heavily with telehealth. Like, what else is on your plate? And, you know, is there anything we can do to help make this doable for you? I know you have that user fee bill we heard the other day. Like, what do you need from us if you think this study is worth doing?
So I think I'm looking into the future on what the committee legislation the committee may vote to put forward and would pass, and that includes just in terms of long-term care, a audit of nursing homes. That is a bill that we understand is being amended as proposed. It's not something we believe is desirable, but the sponsor is working on amendments that may be more feasible. There's a palliative care study. We have a role to play on the so-called Care First bill that probably will begin slowly, but could involve considerable work. We're really excited about some work that we're going to be doing should the advanced directive legislation pass. And then we have one additional piece of legislation on telehealth that may move through the General Assembly and would require a significant investment. I purposely didn't want to talk about the cap because I don't want to, have anyone have the impression that we're holding the committee or the General Assembly hostage. But that's really going to be a major help if we could have more flexibility. Of course, the assessed industries are quick to say that they're challenged. It's a modest amount, I would just say. So I'll leave it at that.
No, I appreciate that. And I appreciate you going through that list with us, because those are all issues I think that are important to the committee. So it gives us a sense of sort of the breadth of what you're working on. I don't see any more hands up from the committee, but I will just tell the committee, as I mentioned before on the last bill, we're going to do next week on the workforce bill so that we can discuss them all in context. So we have 2 weeks before we come back to this bill. So hopefully we'll know a little bit more about what the landscape looks like and be able to make some informed decisions there and continue this discussion. Does that sound like a good plan? Before I call in Eric, does that sound like a good plan to everyone on the committee? Are we comfortable with that? Okay, let's hear from Eric with the last minute. Go ahead, Eric.
Thank you, Chair Kelly. I just wanted to mention it since it hasn't been mentioned in this conversation. Just again, appreciation for the industry. A note about Mr. Steffen's 3 long-term care bills that were mentioned. The nursing home audit, which he mentioned was not desirable. The palliative care bill, which the Alzheimer's Association has weighed in on favorable on. But for this piece of legislation, I just want to emphasize the importance of it, specifically due to the disproportionate impact that the COVID-19 pandemic has had on our long-term care facilities, nursing homes, and assisted living facilities. And as we work to elevate the quality of care for residents and also stabilize the industry where there are over 100 closures a year, I just wanted to, as we think about priorities, mention what we've all been experiencing what residents have been experiencing, and what industry has certainly been experiencing. So thank you again for the time.
Thank you very much. Anything else from anyone on the committee? If not, we will adjourn a minute and a half early, and I will thank the members of the committee very much for their hard work, and we will come back to these two bills in 2 weeks. Next week, we will be discussing workforce issues, lots of different workforce issues, so prepare yourselves and put your thinking caps on because we've got some problems to solve. Thank you. Meeting adjourned.